Welcome to the Texas Conflict Coach radio program. If you've ever experienced or engaged in destructive or unresolved conflict, then you know it leads to broken relationships, distrust, and damaging results. Our program will help you manage and resolve conflict effectively with strategies, valuable resources, and support. Since 2009, our radio program hosted guest experts from around the globe sharing their perspectives, experiences, and expertise while giving you food for thought. If you can't listen live, then download and listen to any of our 300-plus podcasts in our library at texasconflictcoach.com. So sit back, relax, or join the conversation every Tuesday evening, or tweet us at TXConflictCoach.
Well, we continue our healthcare and conflict series with Deescalating the Drama and Healthcare Conflict with our guest, Dr. Haavi Morreim. Quality patient care is critically important not only to the patient receiving services and the family navigating the healthcare system to support their loved one, but it's also very important to the physicians, nurses, and the myriad of healthcare providers who are dedicated to serving their patients. However, the complexity of managing and engaging in our healthcare system is all involved and chock full of emotionally driven conflict and escalated disputes. How can we engage in these conflicts constructively and collaboratively before they get to the courthouse? Our guest, Dr. Haavi Morreim, will share her wealth of experience in the healthcare industry. You will learn how important it is for healthcare providers, hospital systems, and families to work collaboratively together toward quality patient care, and we will discuss communication strategies to support conflict management and resolution. Now, Dr. Haavi Morreim, and I'm going to spell that for you because it's a unique name, so if you are listening live on the web, you can also type her name in. It is H-A-A-V, like in Victor I, last name Morreim, M-O-R-R-E-I-M, like in Mary. Now, Haavi is a professor in the College of Medicine at the University of Tennessee Health Science Center. She does clinical teaching, consulting, and research with special interest in conflict resolution, healthcare's changing economics, and the litigation issues surrounding clinical medical research. Dr. Morreim has authored 2 books and 150 articles in journals of law, medicine, and bioethics, and has presented hundreds of invited lectures nationally and internationally. Haavi is also a licensed attorney and an active mediator for both civil and family litigation. Now, we do have the studio open, and that's 347-324-3591. If you have a question or comment, just simply press number 1, and I'll see you in the studio. We also have our chat room open. If you are, again, listening online, you are at the www.blogtalkradio.com/Texas-conflict-coach. You'll see the show page listed, Deescalating the Drama and Healthcare Conflict, and simply scroll down. You should see the chat room open. That is also another way to engage with us tonight. And finally, we are using the hashtag TCC Radio on Twitter if you're listening and you want to Twitter about the program tonight. Haavi, welcome to our program. I'm so honored to have you.
The upside of it is that with a name like that, all I have to do if I want to Google myself is put Haavi Morreim in quotes, and they're all mine, okay? Because there's nobody else on the planet with that name. So.
Well, again, welcome. I don't know that we heard you at the very beginning, but that's okay. We'll get started here. So first of all, I'm incredibly honored to have you because you're a very busy woman. You have this great depth of experience in this area. This is the first time we're doing a healthcare conflict series, and so I'm so proud to have you and a number of other guests who are helping us and our listeners understand how do we even begin to scratch the surface of navigating better communication when we're working with our healthcare provider. What would be some typical examples of healthcare conflict from your experience?
Well, yeah, I mean, let me, if I may, preface some examples with how did I get these examples? My two fields, as I teach in the medical school, my first field is bioethics, and then also I do health law and teach both of those. And kind of with the ethics hat on, most of my teaching, almost all of it really, over many, many years, more than I'm going to let you know, over many years, my teaching is actually in the clinical setting. I don't teach courses, stand up in front of a blackboard or these days a whiteboard or a PowerPoint lecture in front of a classroom every Monday, Wednesday, and Friday. I'm on the wards talking about real patients and, oh my goodness, what are we going to say to the family at 4 o'clock this afternoon? And oh my gosh, what's going on down the hall? And as a matter of fact, before some of our morning rounds, which are typically at either 7 or 7:30, I'll hear things like the interns and residents will say, "Did you hear what those idiots down the ER did last night?" So I've been watching conflict for decades. And with the ethics hat on, sometimes in hospitals there is a request for what's called an ethics consult. And unfortunately, those usually come later than they really should come, and it's usually after everybody's kind of clawing each other's eyes out and tearing their hair out and all upset about things. And it did not take very long to realize that in most cases, a call for an ethics consult isn't really about ethics, it's about conflict. It's not, in other words, a matter of moral puzzlement, sometimes but rarely. Whatever shall we do, none of us can figure out what's the right thing to do. Instead, much more commonly, it's, I know very well what's the right thing to do. It's those other idiots who don't know what to do. So you come and beat them up for me and tell them, to get straightened up. So conflict, I became interested initially that way, and then just seeing conflict and its very often destructive role in the healthcare process. As Deb Girardi on this program just last week pointed out so well, in healthcare it is much more high stress than the average, workaday thing. I mean, I was just at one of those wonderful national coffee shops the other day, and I ordered my usual decaf, tall decaf, and the person rang up something else, and okay, so, oh yes, I ordered this, not that. Okay, fine, no problem, and it was straightened out. In healthcare, if somebody punches the wrong button, somebody can die because it can be a drug overdose or the wrong drug. Or if somebody says you punched the wrong button, somebody might get very defensive because everybody realizes that mistakes in healthcare can have great ramifications. So some of the kinds of conflicts, with that little background in mind, some of the conflicts we see, just typical examples that happen all the time. You might, for example, have a mother and a stepmother down in the ER arguing about who gets decision-making for the child who's now in the ER being treated for maybe a broken foot at soccer practice, something like that. And stepmom says, well, wait a minute, he was with your dad, it's the weekend, and so I'm the stepmom and dad's on the way, and so I get to make decisions. Mother says, no, I'm the mother. And in one of these cases, actually, the conflict was so heated that they were told, either you go to mediation, which happily that hospital had a mediation service, an in-house conflict resolution service, and they were told either you go to mediation and come to a sensible resolution, or security will escort you both to the door. That's how disruptive it was. In other cases, nurses are in a difficult position because even as they have their own direct responsibilities to patients, which are tremendous, and these days, because people stay in the hospital a shorter time, they tend to be sicker when they're there, and so nurses really have their hands full. And so at the same time, as they have to do their own job, part of their job is second-guessing the physician. If the nurse finds that a drug prescription to his or her knowledge doesn't quite make sense, it is that nurse's job to question the doctor. That's awkward. And some doctors say, oh, thank you so much for calling this to my attention, and others say, I'm the doctor, you're the nurse, mind your own business. And if you don't know what you're going to get, it is an anxiety-producing situation. In other cases, it may be, let's say physicians in a group practice may debate with each other about who has to take night call and weekend call, how are they going to distribute revenues, who has to travel the long distance to the outside clinic, things like that. Just many, many different kinds of conflict are in the healthcare setting.
Absolutely. Now, something you said that, stuck out for me is you said in the healthcare system, especially having the many years of experience of dealing with conflict, is particularly destructive. So why do you think in that system, in that culture, in that community of healthcare and dealing with patients, why do you think it has to be destructive or that it is destructive?
Really good question, Hattie. One of the things that is happening these days is a tremendous transition. Well, correcting myself, there are many transitions going on in healthcare. One of them is in the delivery of healthcare. What used to be a very hierarchical structure has now become very, very team dependent. So that whereas the doctor was the captain of the ship, within my lifetime, nurses were expected to stand to attention when a doctor walked in the room. No more. Happily, that part is long since gone, but still it has long been the case that the doctor is the one who gives the orders, and it was thought the nurse is there just to carry out the orders and everybody else just do what the doctor says. These days, healthcare is much too complex to have that kind of hierarchy, and safety checks and balances are important within healthcare, and so various kinds of providers, physicians, nurses, respiratory therapists, speech therapists, occupational therapists, social workers, chaplains, people need to communicate. And the Joint Commission on Healthcare, as a matter of fact, has found that easily 70% of what they call sentinel events, in other words, events in which something went very wrong, in a very unexpected adverse outcome, in 70% of those, communication was a problem. And another element compounding this is that although electronic medical records, the hope of them, and eventually the reality of them, will be to make healthcare better and safer, the fact is that during this transitional phase, communication is sometimes less, not more. Nurses spend so much of their time checking boxes, and this goes into quality data and quality metrics, that we don't have as much of the nursing narrative in the nursing notes. A lot of physicians have found this to be the case, so that when they go into the chart, look at the nursing notes, they won't find a whole lot there. They won't find, for example, the night nurse describing a conversation in which the patient was very upset and expressed some very important things to that person's care, and it may go nowhere. If the night nurse does not have a chance to talk with the physician and with the day nurses about that conversation, it will go nowhere. And then the family, believing that they do talk to each other, will expect that the doctor will know about this. And then when the doctor obviously is unaware of this conversation, the family will think, well, don't you guys talk to each other? And so that breeds further miscommunication and mistrust. And so healthcare is much more complicated these days. So part of the answer is that transition to a very intensively team-based approach among people who are not entirely accustomed to team-based working.
So, communication becomes so critical and so key. Good communication, effective communication, constructive communication, especially if this is a very team-dependent environment. And I can't even begin to imagine. Certainly, I've been a patient in the healthcare system. I can't even begin to imagine the pressure, the stress, the complexity of working in that system, and I can see how things can, of course, easily escalate. We see conflict escalate so quickly in a very destructive way. Let me just remind folks that you're tuned in to the Texas Conflict Coach Blog Talk radio program, and Dr. Haavi Morreim and I are talking about de-escalating the drama in healthcare conflict and talking about some of the examples and the complexity of the healthcare. So we can go in a couple of places here, and the first is that we know that traditionally protracted conflict is resolved through litigation or litigated mediation. I think you have even talked about that a number of times in your articles. What is litigation mediation?
Yeah, okay. And it's a good concept to put on the table to distinguish it from the kind of mediative activity that I'll do on the wards. Litigation mediation is basically what will often happen after a lawsuit's been filed, after discovery has gone down, and to use the expression, after everybody's been clawing each other's eyes out for years, and they're about ready to go to trial. Often a judge will say, before we actually use the court's time for a full-blown trial, why don't you guys sit down together and try and figure this out with a mediator? Well, when that happens, whether it's in healthcare or any other kind of litigation, the mediation you find there is usually about the money, okay? Now, research has shown very clearly that when an adverse outcome occurs in healthcare, patients and their families want four things. The first thing they want is to find out what happened. Unfortunately, when a family member or a patient says, how did this happen? Often the healthcare providers hear the words, who do I sue? That is not what the patient and family are asking. When they ask what happened, what they want to know is, what happened? And unfortunately, if the healthcare providers get nervous, which is very understandable, but when they get nervous and then start to be quiet and stonewall, what happens often is the patient and family may think, well, if you won't talk to me, maybe you'll talk to a lawyer. And at that point, oh my, good communication no longer has a chance. So in a litigated, okay, let me backtrack here. The first thing that they want to know is what happened. The second thing that they want to know is, how do we improve quality? This must not happen to somebody else. And when hospitals, which, and I'll get in a moment, I'll tell you about a very promising development that more and more hospitals are coming to, which is called offer and disclosure, where they find out that, yes, we did make a mistake. But improving quality is tremendously important to injured patients and their families. This must have some value, some meaning, something worthwhile should come out of this. Somebody else should not have to go through this. The third thing they want is some acknowledgement of what they've gone through. This has been some suffering. This has been inconvenience. It's been a lot, okay? I've been off of work. My family has had less income because of that, whatever it might be. The fourth thing they want is fair compensation. And when hospitals and other providers are willing to say up front, we made a mistake. As a matter of fact, good hospitals these days, when they make a mistake, even when the patient and family don't know that it was an error, they may know it was a bad outcome, but they may not know that an error was made. The hospital will call them in and say, we made a mistake. We want you to know, and we want to tell you what we know so far. We want your help to make care better, and we want to make things right. One of the leading institutions that is doing this is the University of Michigan. Many hospitals now across the country have been adopting this approach. University of Michigan has been at it especially long, and they've got really good data. And what's amazing and encouraging and exciting is they have shown chapter and verse that they are saving a lot of money by doing the right thing. It's called doing well by doing good. And the money they're saving is from defense costs, and they are taking that money and putting it into quality improvement projects. Let's reduce errors. Let's improve communication. And so a number of hospitals have been moving forward in this direction. Those that haven't yet, will. Okay?
And now this is
too
the
clearly a good
disclosure
thing.
and offer programs that you're talking about.
Well, this is the type of program in which, let me tell you, hospitals in their quality improvement processes, they'll know very quickly when something bad happens. They'll know often before the patient and family. They'll know right away because they have information tentacles out throughout the institution. The hospitals that do this well have notified their staff. Anytime something funny happens that you're uncertain about or uncomfortable about, let us know. You will not be blamed. We are not here to jump on your head. Let us find out so that we can find out what's going on to make care better. So they'll know about it, and they'll be inquiring. And when they find out that they have made a mistake that has caused some harm, sometimes even if they've made a mistake that does not cause harm, they will call the patient and family in. And the best programs invite the patient and family, please bring a lawyer. If you don't have one, we'll help you find one, so that the patient and family don't feel all alone on one side of the table with a whole lot of suits, expensive suits on the other side, so that they will feel like they are empowered and have a serious conversation about what has happened, what do we know so far, what are we looking into, we'll keep you posted, and then they do. And at the appropriate point, of course, they will be looking into what is the injury, what kind of compensation is appropriate now and going forward. Not every case can be appropriately compensated up front. And let me emphasize also that in cases where the hospital did not make an error, these hospitals are perfectly happy to litigate. This is not a case of rollover anytime somebody waves a lawyer in front of them. So, this is based on careful inquiry into what happened and was it an error, something we did wrong and should not have done wrong.
So listeners who are tuning in right now and they're hearing you, and I love the fact that you stated the 4 things that injured patients and the families want. What happened? How do we make sure no one else goes through this? Being acknowledged for their harm or their emotion that they went through, and this fair compensation. If they're listening to it now and they're now, we're in this situation, do they go to the hospital? I would assume if the hospital has such a program that they automatically reach out to the patient, but if they don't, does the patient go to the hospital and inquire, or do they say, hey, I want to talk to the X person? Do they say, hey, do you have a disclosure and offer program? How do they take initiative if they wanted to do that?
Often the people who are particularly involved in this, kind of on the front lines, are people called risk managers. I'm not sure that term is an ideal term anymore these days, but risk manager is the term to kind of write down. Can I talk to your risk manager, please? A good risk manager is no longer into the business of, as a dear friend of mine who is very active in this, one of the pioneers of this, Mr. Dale Hetzler, who has been general counsel at Children's Healthcare of Atlanta and also was general counsel at Erlanger in Chattanooga in Tennessee. As he used to call it, the Bart Simpson letter. I didn't do it, you didn't see me do it, and you can't prove anything. Okay, a good risk manager is not going to issue that kind of statement anymore. A good risk manager is going to say, sit down and talk to me. Tell me what your experience is, and use that as a good entree for exploring what happened and finding out more. It may be that a good conversation and an honest and truthful conversation with the patient and family may reveal that actually an error was not made, and that it's the kind of thing that really can happen. And let me add another thing here. Often, physicians feel absolutely awful when something bad happens, even if they made no error whatever. There was a study that came out a couple of years ago that was published in a surgeon's journal where, and I apologize, I can't remember whether it was the 3 months or the 6 months after a serious bad outcome. But the figure, if I recall correctly, so take this with a grain of salt, I'm going on my itty-bitty demented memory here, okay? When a surgeon had made either a significant error or had a bad outcome, 18% contemplated suicide during the 3 or was it 6 months afterwards.
Wow.
Physicians need healing too. They need healing, and unfortunately historically, we don't handle error very well for physicians either. They need to talk about it, they need to analyze it, and so often some of their own colleagues say, well, get over it. Because they're scared of hearing about error too. There was a magnificent paper that came out in the New England Journal of Medicine way back in the 1970s by Dr. David Hilfiker. He described an error that he had made. It was an honest error. It led to the unwitting abortion of a healthy and dearly wanted fetus. It was an understandable thing. He didn't mess up, but it happened. And the healing that he needed was what he talked about, and how badly we handle error for physicians, and how they need communication as well.
Well, and I'm glad that you put it in that way, so it's not always the hospital, the doctor, the healthcare provider against the patient, the family. And I think this is such a complex area and such a complex way in which conflict can easily escalate in a terrible way. And you've already mentioned a number of things, and I want to go into, with what remaining time we have left, to talk about some communication strategies that are going to support collaborative conflict conversation. And so far you've already talked about, listeners who are tuning in, they could ask for their risk managers, that these hospitals are moving in the direction of having these disclosure and offer programs where they can sit at the table and really talk about what happened, how do we improve quality care, how do they get acknowledgement, how do they talk about fair compensation. You even brought up the example of the in-house mediation at the hospital where the two exes were, arguing over the care of their child, and the hospital said, look, you either go do this in-house mediation right now or we're calling security. I mean, so that's good that I think it's very forward-thinking for them to start putting these types of conflict management practices in place. So as far as discussing some communication strategies, what are some things, 2-3 things that you could recommend right now that would help listeners be more collaborative instead of attacking and working with these doctors and providers on how to have more constructive conflict?
Yeah. Basically, several things. One is, when I watch situations on the ward that develop into chronic conflict, often what happens is that providers, because they know they're going to get difficult questions, they avoid going in the room, which just escalates the conflict. One of the best strategies for providers is, early on, if somebody seems hostile or reticent, sit down. That's huge. Sit. Don't stand there. Don't stand with one hand on the doorknob and one foot out the door. Sit, okay, as I have seen done. Sit and ask the person, I see you have concerns. Tell me what's on your mind. Really open question. Doctors are a little bit scared of that. Nurses and other providers can be a little scared of that because time is of the essence. The thing they need to remember is that an investment of time right now in listening and listening some more and listening some more has a huge payoff in time saved later. Healthcare organizations, the Joint Commission for Healthcare Organization, or for the Accreditation of Healthcare Organizations, now called just the Joint Commission, requires that hospitals have conflict resolution approaches in place and policies in place. And so hospitals can do a lot by, as a matter of fact, I'm involved with conflict resolution training. We just did one in Little Rock, Arkansas, a couple of weeks ago. We had physicians, we had nurses, social work, chaplains, risk management, 2 lawyers, and we did a lot of mediate and debrief, very practical, hands-on exercises in how to listen and how to help people who are in conflict. And as I like to say, and I just finished teaching a similar course to fourth-year medical students. As I love to say, you'll learn a lot about conflict by watching other people fight and helping other people who are fighting come to a resolution, even if it's a mock mediation where people are playing roles. So that's another thing that can be done. From the family and patient side, when you have a concern, and I'll finish with this one, when you have a concern, try to use I statements, as they're called, instead of saying, how come and why did you? Describe where you are. When this happens, I feel such and such. I feel scared. When I call and no one answers, I feel scared because I'm afraid things will go downhill if I don't have someone. I feel like things are not under control, that I have any control here, and so I'm afraid. Use those I statements. Those are non-threatening, and healthcare providers are much more comfortable listening to that kind of statement than, how come you guys don't come when I call?
Yes, because, anytime anyone feels backed in a corner, right, a doctor feels backed in the corner, has got his hand on that doorknob, as you said, ready to walk out, run out.
I'm out of here.
Yeah, exactly. So the more, and so I like the way that you've talked from both angles in the sense of, for families and patients who are already hurting, they're very fearful, very anxious about what's either happened, going to happen. Part of it is that them taking, what you're saying is take a step back, let them know how this is impacting you, let them know what the behavior is, let them know how it is you're feeling so that they can hear you. And then for the provider side, and I love the fact that we're hearing more and more of this conflict resolution training, communication, listening, which are critical elements and skills in being in that industry, that it's a critical skill set. It's no longer, I heard someone say the other day, this is no longer a soft skill, this is the new hard skill.
I love it.
They've got to learn to be able to acknowledge, to be able to listen, to be able to open those questions and not do that from a defensive place, but from a place of real genuine concern and hearing beyond that upsetness from the family and the patient. Now, we usually, I know as we were starting to, there's so much to talk about. I wish we had more time, which is why we make this a whole series. And I appreciate, you putting it down in these short little nuggets, but at least it's a start. And for those who are listening to the program, and what do you really want listeners, if they're hang up the program and they're like, man, I could have done a better job of communicating with my doctor, or maybe I haven't even asked the doctor the question, I'm still confused. What is the assignment for the week, the thing that our listener can take the next step? What would you suggest?
Okay, and I am going to divide this according to the provider side and the patient and family side. For the provider side, a wonderful question that doesn't get asked often enough is, tell me more. When somebody has said something that maybe puzzles you, or even if you think you do know what the person said, tell me more. Help me understand more about what you're asking or what you're telling me. Tell me more. It's a really good way to get at things. And in the same vein, summarizing what you think you've heard. If I hear you correctly, here's what I think I've heard. And that goes as well for the patient side. If I've heard you correctly, doctor, this is what I think you've said. Is that right? If I got it about right? And two things that does. It shows you're listening, and it lets the other side know how they've come across so that you can begin to pinpoint where things have not gone right and need clarification.
And I find that from the patient side, being on the patient side, and I am a conflict resolution practitioner of 20 years, that I find myself when I'm with doctors, depending on the personality of the doctor, that it can be really scary to be able to question the doctor's orders or what he just said. And so it's like not being afraid to say, this is what I heard, this is what I understood. I need to ask more questions for understanding. It's okay, if you've got some anxiety around that, but the thing is to have that conversation and not to be fearful of the doctor that he knows what he's doing, so I guess I'm not going to question it or I'm not going to clarify. I think it's really important that it's our responsibility as patients to be part of that communication loop and keeping that open and constructive.
Yeah, and you can do it in a fairly non-threatening way. By saying, help me understand, is a lot less threatening than, how come X? How come you said X? Help me understand better is a nice non-threatening way to put some of these things.
Yes, absolutely. So I appreciate the assignments that you've given to both sides. So providers, tell me more. Summarize what you have heard to make sure that you are understanding yourself, and the same for the family or the patient. Help me understand better. Ask the question. Even for yourself, summarize. This is what I understood you to say. I'm going to physical therapy 3 times a week. I'm going to do that for 6 weeks. Whatever that is, or even taking notes to help you remember or to go back if you have to ask for the question. So I appreciate that assignment for the week, and I hope, folks, that you're listening, that you'll do that right away the next time you're having that conversation with your healthcare provider. Haavi, there's so much to talk about in this topic, and that's why you're so good at what you do and helping the industry that you do through your background experience. What final message? Well, actually, let me ask you. Let me let you tell people how they can reach you, because you do have a website. So, how's it best for people to find out about you and to contact you?
You betcha. Probably for this purpose, I've got, of course, my university side, but then also I am principal in what's called the ADR Institute, and that's ADR for Alternative Dispute Resolution. And so the email address for that will be H. Morreim, and that's H for Haavi, HMORREIM, like Mary, at ADRINST.com. ADR for Alternative Dispute Resolution, and INST for short for Institute. So it's HMORREIM at ADRINST.com. And if they want a phone number, 901-755-7479. Probably email is the best to avoid telephone tag.
Okay, great. And folks, on the show page, we also have Haavi's website, which is ADRINST.com. So you can look at her website, and they're getting some additional things. They also are on social media with Facebook and Twitter for those who like to engage in that way as well. Haavi,
and I might add, right now, the website does not yet have our conflict resolution training up there, but it shortly will be. We're in the process of revamping the website, and so if they want to know about upcoming healthcare conflict resolution trainings, including what is also called bioethics mediation skills, just give me an email, and I'll be able to provide further information on that.
That's
soon
wonderful.
We will have the website updated.
That's awesome, because we do have a large ADR practitioner following who listen to the programs, and I'm sure there's quite a few people who would be interested in that type of a training. I see that you have some civil mediation training on your website now, but I see that you have a number of trainings up there. So as you get that up, folks be looking at that website, and or, as you said, to email Haavi if you're interested in taking that bioethics mediation. There's not many of those types of trainings out there right now at all. That I know of. So, well, Haavi, what final message would you like to leave with our listeners tonight?
Oh, my goodness. Conflict is inevitable, but with good quality listening, it can be reduced considerably. And with collaborative problem solving, it can be an opportunity to change for the better.
Wonderful. Thank you so much again for blessing us and having you on the program tonight and being part of our healthcare and conflict series.
My pleasure. Thank you for the invitation.
All right. Good night.
Good night.
Thank you for listening to the Texas Conflict Coach. We hope you've enjoyed the program. You can find over 300 podcasts archived to listen at your own convenience at texasconflictcoach.com. or download the podcast at iTunes or Stitcher Radio. To learn about upcoming radio programs and resources, sign up for our monthly e-newsletter.